Good evening, everyone. My name is Shikha Patel Shah, and this presentation review is the evidence-based pharmacological management of otitis media in an adolescent patient. I will discuss first and second line therapies, clinical rationale, monitoring parameters, and the patient-centered education to support clinical optimal outcomes. Let's begin with patient overview. Emily is a 17-year-old presenting with unilateral ear pain, decreased hearing, and low-grade fever for 3 days. The absence of allergies and chronic conditions simplifies our antibiotic selection. Her age and symptom duration supports active treatment rather than watchful waiting. Otitis media, or acute otitis media, is diagnosis for the clinically based on middle ear inflammation and effusion. High-dose amoxicillin remains the first-line treatment per current guidelines due to its strong efficacy against Streptococcus pneumoniae and favorable safety profile. It inhibits bacterial cell wall synthesis, leading to bactericidal activity. Its pharmacodynamics are time-dependent, meaning efficacy is optimized when drug concentration remains above the minimum inhibitory concentration. It is well absorbed orally and primarily excreted, unchanged in the urine. Combination of amoxicillin and clavulanate is recommended in the case of treatment failure. Recent antibiotic use or suspected beta-lactamase producing organisms, clavulanate inhibits beta-lactamase enzymes, extending coverage to resistant Haemophilus influenza and Moraxella catarrhalis. This combination broadens antibiotic or antimicrobial coverage while maintaining bactericidal activity. The prescription would be as follows. It would be amoxicillin, 875 milligrams PO twice daily for 5 to 7 days. For this prescription, I would not include any refills because acute otitis media is a short-term infection that should resolve in a single course of antibiotics if symptoms persist. The patient should be reevaluated rather than automatically continuing therapy. Amoxicillin can be taken with or without food, but I recommend taking it with food to help minimize GI side effects such as nausea and stomach discomfort, which can improve adherence. The patient should take each dose with a full glass of water to support proper absorption and reduce the risk of esophageal irritation. It's important to emphasize completing full course of antibiotics even if symptoms improve early, to ensure the complete eradication of infection and reduce the risk for antibiotic resistance. Common adverse effects include GI upset due to alteration of normal gut flora, as well as hypersensitivity reactions such as rash. Although rare, patients should be counseled for signs of anaphylaxis. There is also potential interaction with anticoagulants, which can increase the risk of bleeding, and theoretical reduction of oral contraceptive efficacy. So, precautionary counseling is appropriate. Clinical improvement should occur within 48 to 72 hours, including reducing in pain and fever. Lack of improvement may indicate resistance to organism or an alternative diagnosis. Monitoring also includes assessing for adverse drug reactions and adherence. Renal function monitoring is generally not necessary in short courses unless the patient has underlying kidney disease. For non-pharmacological treatments, adjunctive management focuses on symptom relief. Evidence support the use of analgesics such as acetaminophen or NSAIDs for pain control, which is often the most distressing symptom. Supportive care include hydration, rest, contributes to overall recovery, but does not replace antibiotic therapy in the symptomatic cases like this. Patient education is critical to ensure adherence and prevent complications. Emily should be instructed to complete the full course of antibiotics even if symptoms improve. She should be aware of potential side effects, including gastrointestinal symptoms and rash, and advised to seek care if symptoms worsen or fail to improve. If she uses oral contraceptive, backup contraception should be discussed as a precaution. And finally, these are the following references I have used to gauge my clinical reasoning. Thank you everyone for watching my presentation. All the best.